sleep. So here's where we finished off talking about the kidney. Not going to be a lot of crazy anatomy situations unless it really applies, and where that does apply we'll get into right here in a bit. So this is why I pick up the phone a lot of times and we'll call a urologist if it's something that's awkward or whatnot on a CT scan. Because all these things play a factor in whether or not that person's going to have a quick versus painful, long duration of passing their kidney stone. And that's obviously by size. That's probably the biggest thing. And then shape of that. Is it irregular? Does it have what's called spicules, which is just like tiny little spines that stick out of it that make it less likely to pass spontaneously? Also causes a lot more bleeding. And obviously the location. Back in the day, they used to just do a KUB, kidney, ureter, bladder, an X-ray, just to see where that stone was, and then just to repeat it, just looking for migration to make sure it's moved along, get an idea of what the size of it was. They may do that rather than a CT to check that, but that's urology's game. And then obviously the degree of obstruction. A lot of times that is figured out, whether stone size and ureter size, so that's more of an anatomy thing. So with a smaller ureter, more likely it's going to be obstructed. It can be partially obstructed complete. Just keep in mind that a CT scan or an X-ray is just a snapshot in time. It's not a continuous type of thing. So snapshot in time. Now when I focus on those locations, I got a great slide for you so you can visualize that. So the UPJ right there is the #1 location. And why? That's where the pelvis constricts down to, in that area, to 2 to 3 centimeters within the ureter. So that's going to be the #1 spot. And you're going to get another area is the pelvic brim, where the ureter courses over both the pelvis and the iliac vessels, so it's going to constrict a little bit more there. And then finally, the UVJ, most constricted side of the ureter and muscular coat of the bladder. But that doesn't mean that that's necessarily how that works out. So again, UPJ, #1 spot. UVJ, right down there a little bit lower, so you see it kind of goes 1, 2, and then back up to 3 to the pelvic brim. What that means is that's likely what the urologist is going to say when you pick them up. Pick it up on the phone, they're going to say, what's the size of it, where's it at? You say, oh, 5mm stone, seems regularly shaped, and it's most likely it's going to be at the UPJ. Secondly, is it's almost on its way out, it's going to be at the UVJ, and then the other spot that it can get caught up a little bit more is the pelvic brim. Now we'll talk about size. 98% of stones less than 5mm, so that's kind of our cutoff. When we say less than 5mm, means that these are probably going to pass. Now look at that, 4 weeks. That's why I say that friend's episode, like he came in the hospital, and you really see a timeline there, but it's about 4 weeks, about average. And then we get bigger, we get 5 to 7mm, 60%, and greater than 7 millimeters, but only 40%. And all within 4 weeks. So you can imagine that person's going to need a decent amount of medication for that 4 weeks if they're constantly having that. Now it's not like a constant, all the time pain, but it's a colicky type pain. So a lot of these people not drink lots of water, because the more water they drink, the more fluids they drink, it's more that's going to cause that peristalsis, that colicky pain that goes down the ureters as that urine works its way to the bladder. So just think about that. It's a long time to be on pain medication, but we want to make sure they get good follow-up, make sure that they have a strainer and stuff. We'll talk a little bit more about that. Just be aware if you're on an X-ray, if you're using X-ray for whatever reason, the stone image can be magnified up to 20%. So looks a little bit bigger on X-ray, looks a little bit smaller on CT. 80% of the actual stone size, so just be aware. It's usually a little bit bigger. What does that mean for me? What does this slide mean for you? If that person has larger than a 5mm stone, I'm going to go ahead and give urology a call. Chances are, their experience, they see this stuff all day long. They're going to advise me, hey, go ahead and start on the stone protocol. creatinine looks fine, and we're not worried about it being infected. It'll be just good to go. But at least I feel advised that I can put that in the note that says urology, discuss the case with them, they are fine with discharge, putting the patient on symptomatic medications. That also earmarks that patient for when that consult goes through to urology. Now like, oh yeah, I remember I talked to the ER guy about that guy, so I think he'll be okay. So, versus if they do come in earlier, at least they have an idea if they're having complications. You call them again, be like, we already talked to you guys, and this dude's back again, so I need you to really come down to the ER and see him. At a urologist, you've got to come in 3 days before Christmas for a kidney stone, like an 8mm stone. They called urology, and they said, yeah, he's good to go home. I said, 8mm. You really sure? She goes, yeah, it's fine. I said, cool, so when he comes back in on Christmas Day, you have to get up from a Christmas dinner and come into work to see this guy. That's how you want to go? She's like, I'll be right there. So, played it a little bit, but yeah, I'm just trying to help that person out. Plus, my patient got urology in his own, so didn't change anything, but I felt better about it. Alrighty, classic symptoms. Acute onset, so it comes on very quickly. Crampy, intermittent, because it's colicky in nature, comes and goes. Flank pain, and typically will radiate down to the groin. So remember, it's a ureter, it's a hollow viscous, so we're going to have that visceral pain initially, and then once that gets inflamed, we start getting that parietal, that affecting the peritoneum, and typically that ureter is more anterior, so we're not going to be describing that, but if it is more kind of UPJ, where it's more proximal and stuff towards the kidneys, and the kidneys are what? The retroperitoneal, then we can have a little bit more flank pain. Just think about how that, so these people are typically, like, they're not laying comfortably in bed, because that pain's coming on and off. They cannot be comfortable. So, you get rebound tenderness, guarding, rigidity, any number of those things. Guarding being the most common. Now that's voluntary. So rigidity does that on its own. Guarding is considered voluntary because they're in pain. So usually most common with nausea and vomiting from the pain. So people can come in with abnormal vitals as well, and that's just an adrenergic response. They can be tachycardic, should not be severely tachycardic, but anytime somebody's in pain, you can expect some tachycardia, hypertension, and definitely some diaphoresis. So, again, we have hematuria in there. Most of the time it's microscopic, 85% of the time, but we can have 30% of the time. Also, 85%, which is renal colic, and then 30% will have gross hematuria. They will actually see blood when they urinate. So, what do you want to ask these patients? We do not want to leave these three things out. Very important. We want to make sure that there's risk factors for stone development. We've already talked about all those: obesity, sedentary lifestyle, not drinking enough fluids. So prior stone outcome, always good thing. Have you had a kidney stone before? Cool. Can you also tell me what type of kidney stones you have? Because we'll take a deeper dive into that. And then important mimickers. What do we get worried about? Talk about another slide. I want to steal its thunder, but older people, you need to be very concerned. Older people typically get kidney stones. It's usually something much, much more serious. Here are those mimickers. So, not a kidney stone. We get worried about abdominal aortic aneurysms. Older people. These are things you do not want to miss. And a renal artery infarction. Probably have some underlying atrial fibrillation, whether that's constant or paroxysmal, or which means it comes and goes, paroxysmal. I have had a gentleman come in, he had his entire kidney just complete blood supply shot, infarcted. It's done, they gotta go in there and remove it. So again, you got somebody that comes in, get them up there at age 50, 60, 70s, they come in, they're complaining of flank pain, they say, I think it's a kidney stone, or I think it's a ureteral lithiasis, they're probably not going to say that. It's a stone in my ureter. Sad thing is maybe they did have a history of kidney stones, and you go down that route. Be careful with that. We're going to miss these AAAs. We're going to miss these renal infarctions. So these people should not have hypotension, flank pain, radiating down the groin, hypotension, we need to be thinking this is something much more serious. So, can mimic stones, especially with that renal infarction, because it's going to cause swelling in that infected kidney, and it's also going to cause hematuria, which is going to really, really mix up, muddy the waters, if you will. You're going to get complicated patients like that. It's not going to be slam dunk patients like the trauma test. You get some people that have like 5 different things going on. So not only got to put a chest tube in, you're also got to intubate or crike. Several different things going on. Just be ready. So these are things that we need to be thinking about during your HPI. You've got to get knowledge of this. Sometimes the patients are not the best historians, so you're going to do a little bit of detective work. Their records, so stone development from slide 8, outcome. Also get an idea of history of their renal disease. They have any underlying renal issues. Obviously not going to be a big deal because we're going to order a non-con. Don't get too crazy about that, but worry about those members. Poor outcomes for this is if their renal function is at risk. So they've had a history of difficult stones, meaning they get obstructed or they get infected. An infected, obstructed stone is a medical emergency. You're going to call urology, probably start them on antibiotics, and then come to the hospital. Potentially get surgerized. Talk about those things. The diagnosis. So we want to make sure that we're looking for infection. So white count is going to be very important. Red blood cell counts or leukocytosis, kidney dysfunction. I want to make sure that this patient is not pregnant, because it is possible to have kidney stones during pregnancy, which really makes things tough. So essentially, we get a CBC, BNP, some abdominal pain, might as well get our LFTs plus or minus on the lipase. Obviously, UA. And then I ordered those labs, and I'm going to definitely get imaging. I just got to wait on that UA to come back. So I need to make a decision, am I going for a CT with IV contrast, or am I going to a non-contrast, because I'm thinking more, there's hematuria, this is more urinary symptoms. So, obviously a pregnancy test, because we're talking about potentially right or left lower quadrant pain or radiating down to the groin, and make sure that there's no concern for ectopic. That'll send us down a different path, keeping us away probably from doing radiologic studies. We need to be reaching for ultrasound earlier. We do not want to radiate a fetus. So UA gives us an idea if that's an infected stone. So we can see a little bit of elevation in that CBC occasionally from some stress or marginalized leukocytosis. And you get stressed, your white count can go up. But we want to get an idea, what are we looking for in that UA? We want to see WBCs, and then we want to see one of 2 different things. What makes a UA typically positive? Undercut leukocytesterase, and then also nitrite, right? So bacteria in the bladder turns nitrate into nitrites. Crazy how that works, but gives you an idea of something's going on. You're definitely, if that comes back positive, you're definitely going to order a culture. We just want to make sure it's not some funky bug, and we're going to have appropriate antibiotic coverage for that patient. With kiddos with kidney stones, yes, they can have them. It's usually some underlying metabolic disorder, not very common, but we need to make sure we're getting the urine culture, because a lot of times they can just have some sterile pyuria. Remember, sterile pyuria, they have white blood cells, but you send in the culture and nothing goes out. Okay, make sure we check that renal function, because if it's so obstructed, because they have small ureters and big stones, or irregularly shaped stones, or it's way up in the UPJ, we need to make sure we're assessing that renal function. That is, if we have a significant change in the renal function, you definitely need to get urology info. So that means that's backing up. It's backing up and higher suspicion for infection, it just hasn't started yet. So we need to look like that, look for that. Don't get too worried about white counts unless the patient's febrile or you have a concern for sepsis. We talked about all those different things that can mimic a leukocytosis, steroids, thyroid meds. There's potential that urology, if you called it and they say, hey, can you just go ahead and order a calcium That's separate. Calcium and mag are not part of those regular basic metabolic panels or comprehensive metabolic panel. So they may say, hey, can you just get a calcium and uric acid level? Just want to determine long-term therapy. Not useful for you in the emergency department, but I'll do somebody a solid out of courtesy if I can tee them up. Especially in these COVID times, I found myself doing a lot more primary care and a lot more workups on people because they can't get in to see their primary care. And then I asked them, do you have a primary care? Yeah, I can't get in to see him, so you're my primary care. I don't think that's necessarily appropriate, but at the time it was with COVID and everything, so I did a lot of workups on people. And if I had somebody coming with kidney stones, I would go ahead and tee them up and order a calcium and uric acid and have it sit down. So when they did finally get in to see urology or their primary care, they at least have a little bit better idea of what's going on. And some people just need a little bit more reassurance as well. So again, we get imaging on that. We need to confirm that it's a stone, not something else. Again, we don't want to miss those great mimickers in older folks, and sometimes younger folks can have those types of things too, very atypical, but not completely not possible. So we want to ID those complications, especially the stone location. So we make an idea that if they shoot another one, that stone hopefully has moved. If that hasn't moved, that's not good. It's not good. So, right there, imaging recommended by the American Urologic Association. That is for all first-time stoners. Come on. All people with first-time stones. That's too early, I guess. Whatever. I look forward to that joke every time. Anyway, so your first time, yeah. Tough crowd, man. You guys are running hell. Suspected first-time stone producers. We want to get imaging on those folks. So, if you have a young, healthy person, sometimes we can defer that. I usually go ahead and just go ahead and get it. That patient wants to know how far that's working. Because why we end up with incorrect diagnosis 20 to 70% of the time without imaging. Plus, if I go to CT, non-con, and I can't find a kidney stone, I'm like, what else could this be? And maybe I need to get a CT with IV contrast. Something else, something for else. Great. How does that look for you? You think it's a kidney stone, they have hematuria, they've got a white count, flank pain, right down the groin. CT scan still can reveal a third of the time that that's not the diagnosis. Not the diagnosis. Just be aware, that doesn't mean I do look back in people's history. This is a double-edged sword, and that I see people that get CT'd all the time and don't find anything. They keep CT'ing them like every week. I'm like, there's a lot of radiation. Versus the person that's come in with like headaches every month, severe headaches, and just gets a migraine cocktail and sent home like after the 5th month. Somebody goes, oh, maybe we should CT this, and then come back with a nasty Goomba, like a brain tumor. So double-edged sword with, using that liberally, probably a little bit more liberal in the emergency department, but just be aware how much you are accumulating radiation in these people. Remember, CT scan is 10 more than an X-ray. And always, always, always beware of your bounce backs. Beware of your bounce backs. Non-con, this is about like the only time, unless somebody can't handle contrast, you reach for the non-con. Reach for the non-con, and a lot of times I'll say it'll list in Genesis non-contrast CT of the abdomen and pelvis, parentheses, stone protocol. So that, and then you're going to type in a little thing like patients, 35-year-old coming in with left flank pain, radiating down to the left groin, put in some labs UA with hematuria. Please evaluate for, give them a little bit of idea on that. Please evaluate for, ureterolithiasis. Gives you a better idea of that. So they're going to scan that all the way from the top of the kidney all the way down to the bladder for you. How the kidney to the base of the bladder. A lot of times, you want to see, there are sometimes there are stones that are floating around there. Just keep in mind it is possible for somebody to have several kidney stones, so don't just get locked in like there's only one there. So, what is that going to read? They're going to send you back your report, and they're going to say whether there's dilation of the ureter. They're going to call something called paranephritic fat straining, which just means inflammation in the kidney stone, dilation of the collecting system, usually hydronephrosis, renal enlargement, and then they're going to tell you how big that stone is and where it is. Snapshot in time though, so you don't know if it's moving. It could be obstructed. That's fine. If they're producing urine, chances are not super obstructed, but as long as that kidney function comes back okay. So a lot of these are radio opaque, so we can see them 90% because they're calcium. Calcium stones are your most common, up at 90%. And you have these struvite stones. We talked about those. Slightly radiodense, so a little bit more difficult to pick up. Those are more concerning. Those are the ones that get infected and antibiotics don't work well on. And then our cysteine, those people that have that underlying hereditary condition. And then again, urinary stones sometimes less visible on plain films, which is why we don't go that. I told you that old school is that KUB. You're probably using that in like other countries that don't have the capability of CT scanners, but we have lots of CT scanners in the United States, so we need to deal with that. It can possibly be followed with a KUB, but I'm going to wait for a urology guy to tell me, hey, they're back in, cool, just shoot a KUB, I'll take a look at it and just make sure it's moving along. I'm not going to be like willy-nilly doing that on my own. I'm going to be doing that within consultation. That's why those folks are there. Sometimes they may get a little upset if you're calling them on the phone. But I'm like, you know, you're the specialist, you're the subject matter expert. That's why I'm calling you. That's why you have a pager. Now, if I call you twice in the same day with the same question, yeah, you can be upset. I didn't learn my lesson the first time. I get it. But I'm not do that. Ultrasound is what we reach for in pregnant patients. What are we looking for? Usually formal ultrasound is not going to be your point of care ultrasound. Formal ultrasound means they go over and see an ultrasound tech. That tech's going to take way more images than we ever would at a point of care ultrasound, and a radiologist will look at all those images. So, for sensitivity, finding stones, we're not necessarily doing that. Our biggest thing we're looking for is, do we see hydronephrosis? It's going to give us an idea of the kidney size, and then we can look at and they have good blood flow. So we're not getting a whole bunch of answers with this. We're not figuring out the size of the kidney stone, but we also have a pregnant patient that can radiate. So if she has a kidney stone, we may not find it, but if we do have no evidence of hydronephrosis, we can pretty much rest assured that we're not dealing with an obstruction. Now, how does that look? Numerous stones with what we call acoustic shadow, because it's sound waves, even though we can't hear it. It's acoustic shadow. And you're shining that, and gives them an idea that those are stones that are within the kidney. For your visual folks, right here. Bunch of different things. Obviously, they have plain abdominal fan, radiographs, ultrasound, an IV urogram. It's just to evaluate renal function. It's not really going to tell you anything about stones. So again, your non-contrast CT is where you might use that on problem radiation. Also, no evaluation of renal function, but an idea of that. Obviously, if you get asked any question, obviously it's going to be you're not done. Treatment. What do we do? These are folks before I even evaluate them. I need to get some meds on board. I'm not going to start trying to touch somebody, check for CVA tenderness if they're in that much pain and extremis from a kidney stone. And there's potential. These people are writhing around in bed so much that you might have to use some type of IM pain medication. I've had to give IM morphine because the person could not lay still enough to get an IV. So I give medications. So pain, nausea, want to get that stuff under control well before you start asking your patient questions. So antibiotics, reach for that early if there's signs of infection. I would do that usually in concert with my urology folks, and then medical expulsion therapy. That's our alpha adrenergic blockers. But we'll talk about that a little bit more. A lot of people say, well, we should give them lots of fluids. No, we don't need to do that. It's not really going to help out with minimal hydration. Now, we do tell them to drink lots of fluids, but I'm going to tell you right now, they're not going to drink lots of fluids. Why? Because every time they drink, it's going to cause those ureters to start peristalsis. It's going to get colicky pain. So, pretty tough for these folks. That is why we got to get them under their pain under control. So, but just be aware, if they have been vomiting a lot and they are fluid down, they have not produced urine, then you need to give them fluids so they can give you some urine. Or if they're volume down, we check that stuff. So, aside from doing tilts, what's another way to check if somebody is dehydrated besides labs? Skin checking, right? You pull on that skin, it should pop back. It's pretty quick. Now, the older people get, the more leathery they get. Not always affecting them, but for this is a younger person type of disease. NSAIDs. So, yes, if they're riding around in pain, you have to have a low threshold to give some people some good pain medication, provided their blood pressure can handle it. So, fentanyl is a good gauge, gliders are good as far as people that are potentially hypertensive, be careful with morphine. But NSAIDs, why? Because it acts on that colicky type of thing. Acts on the colicky type thing. It inhibits the prostaglandin synthesis. So, we look at ketorolac as being your top one, aka Toradol. What's the max you can give IV? It's right there at 30. So sometimes if I want to leave a little bit of threshold, they're not that much pain, I'll give them 15 and then save another 15 for later. And potentially go to some other type of IV opioid. How much can you give up IM? Like 60. Be careful with that, with your dudes that are, if you guys are ruck marching. Not a good thing to give somebody 60 milligrams of Toradol IM after they've rocked 25 miles. So, unless you want to give them rapid, let's see what that looks like. Just be aware. So some people don't realize that NSAIDs, actually there are a lot of people out there that are actually allergic to NSAIDs. I can't tell you the number of people that have given a Toradol shot and the fast track, and the next thing I know, they're coming in for anaphylaxis when they decide to see me. So it actually happens. So just be cautious about that. One of the things you give these people, monitor them. If they've never had that, they can have a hypersensitivity. We obviously avoid that in people who are anticoagulated or have some underlying coagulopathy and increased risk of GI bleeding. And then there is also increased risk that they do have some renal impairment that can potentially be nephrotoxic. What are they going to do? Potentially urology, and that's why I give them a call if it's a bigger stone. Maybe they're not have nothing to do with lithotripsy. They can break up that stone with waves. So just be aware of the medication, and you have to be careful within 3 to 10 days if that's what's going to happen. If there's anything on platelet, what affects platelets? Pretty much just aspirin for the most part. But I would let them know if they're anticoagulated. Just talk to urology if they're going to plan on doing that. They should advise them on that, but I need you to be aware. Everybody will probably do a urology rotation, usually in concert with your general surgery. I know Barrington has a urology PA, so that's pretty exciting stuff. So NSAIDs are not enough. We can reach for narcotics. Just realize that that's not acting on the same way that the NSAIDs are going to do with the colicky type of pain, but it may be if their pain's not under control. And if you reach for opioids and they're not having nausea vomiting, please give an antiemetic before you give an opioid. People that are opioid naive can get very sick from that and they'll be throwing up, which is complicates things. And also, Reglan is another medication. Obviously, double-blinded studies there can be considered. Medication for reaching works really good for headaches, obviously off-label, if you will, because it's an antiemetic, pro-motility, but it also helps out a lot with kidney stones, and it also relieves nausea, so that's like 2 birds with 1 stone. So again, we need to admit these people if we're about they have a stone, they have fever, we see signs of renal insufficiency and then systemic signs of infection. That's infected, obstructed stone. Some reason, I talked about this the other day, but this gets admitted to urology. It does not go to general surgery just because you think it might need surgery. They have to go in on potential that they put in, either do some lithotripsy or put in a stent. So, urinary tract infection, these can mostly be treated as outpatient, provided we get everything under control. No evidence of obstruction, fever, or systemic illness. Go home 48 hours. 72 hours, hopefully they can get back in. What's one of the things that we reach for? Tamsulosin, alpha blocker. Alpha blocker. Most commonly used medication. Now there's studies back and forth. It's like 50-50 that it works, 50-50, or 50 that it doesn't. 50% say it works. Every urologist that I've talked to says give them the Flomax. If they have a chance of passing it, please give them the Flomax. So just be aware of that. It usually decreases the amount of time for expulsion, also decreases the need for analgesia, so I'm definitely going to add that. What do we get worried about with this is that we're giving that to somebody that has an underlying high blood pressure, hypertension, because it can cause orthostatic hypotension. And if you give somebody a medication and they syncopize behind the wheel of their vehicle and wreck it, they're coming for you. So how do I combat that? They take their high blood pressure medication, hydrochlorothiazide, their ACE inhibitor, their ARB, whatever, beta blocker in the morning. I tell them, take this one at night. And I offset it. Take this one at night, you're not taking it at the same time. It should be good to go. Just be just advise them on that. But huge caution with your hypertension patients. There we go, just for you visual learners. Obviously there are absolute indications. Absolutes, like you just pick up the phone and say, urology, hey, I got this down here, come get your patient, and list one of those, whether that's intractable pain or vomiting. So, urosepsis. So another reason to get that CT or talk to that patient, make sure you have good medical history. I can't tell you a number of times where I found somebody with a horseshoe kidney, that is just a single kidney. It's basically in the back, very uncommon. Or maybe that person never knew that they had a kidney that didn't grow, so aplastic kidney. We found here in ultrasound before, explore so. And then hypercalcemic crisis, concerned about that. And then just these older folks, make sure you're not missing those mimickers. And then you have all your relative indications. What that means for me is I usually need 3 of those before I start thinking I need to make the patient 3 of those. So, what does that look like? Urinary extravasation. That's kind of crazy. That sounds like that should be moved to absolute indications, but that's just me. That's just me. Here's your disposition. Most patients go out. Okay. You talk to them that they're likely to pass this, but we need to get them a strainer, because we need them to bring that stone back in so we can figure out what it is. Again, I pick up the phone if it's greater than 5 millimeters, if they say something about it's very irregular, or that it's all the way like maybe just coming out of the kidney, as you can get that UPJ yet, I may give them a ring. But disposition with all these other folks, we discussed that as well. Multiple visits to the emergency department. Look, this guy's been here 3 times this week. Can you please come down and see him? Just indulge you, so they're just going to come back again. Pick up the phone if you have any questions, you kind of develop that rapport. Most hospitals have gone to a good algorithm based for like a lot of these common complaints, which are kidney stones, appendicitis, cholecystitis, where they give you like a little chart and go down and they say, hey, follow the chart and for the next call. It's like, oh, glad you actually looked that up. I appreciate that. So, small stones usually go home as long as there's no infection, the PO tolerant, no renal insufficiency. Strainer, very important. They're going to use that all the time. Hopefully, collect that kidney stone. And stones are on their own plan based on their their size and location, mirror your size, stone size. 7 to 30 days for stones to pass that are about 5 to 6 centimeters. That's just something to look back and look at all the numbers from around. So, strict term precautions always given from the emergency department. I just say any change, they're going to change. I don't get down to like you have fever, uncontrollable vomiting, pain, not controlled oral medications. You can say that. I just say if you have any change in symptoms, worsening symptoms, any other concerns. Usually opiates, NSAIDs, expulsion therapy, antiemetics. So you don't send them home with all 4 of those, you have a good chance to see them again. So in a perfect world, they see urology within a week. In a perfect world. But our medical landscape has already shown that we're not gonna, in the next like 20 years, we're not gonna have urologists go around. If they do happen to pass that stone in the ED, which would be amazing, and hopefully they collect it, they're pain-free, PO challenge and go. Elective urologic consultation, so make sure, again, I get visibility from urology that they know there's a patient out there. Eventually, they're gonna figure out, is there medications they can be put on prophylactically to stop their stones. There's a bunch of different things. So they have to have that stone, an idea of what it is. Even if you have negative workup and that person comes in with hematuria and it's microscopic in nature, that still needs a consult to urology because they need to figure out why that person is having hematuria. Were they working out too hard, or is this an early cancer and they need to get a scope? Either way, hematuria that's unexplained needs a consult to urology. So either way, you put the consult in. Pregnancy. So unfortunately, yes, most of these present in the 2nd and 3rd trimester. So same way as non-pregnant patients, flame pain, hematuria, more hematuria than flame pain. And I want to make sure they do recognize now this is going to be for 2nd and 3rd trimester. They're going to say, yeah, we're going to recommend you get a CT scan. But you're going to probably still pick up the phone, call OBGYN, call urology, make sure that everybody's in agreement that we're going to do that. Do not reach for NSAIDs with pregnant patients. Why? Because that affects too much prostaglandin with the fetus. Make sure that we're usually opioids, but it's okay to reach for tamsulosin, so alpha blocker. Okay, category B, be sure where that. That'll probably be most of what you're going to get out of your OBGYN rotation is what's okay with pregnant patients and what's not. Children, not very common, so we need to be concerned that there's some type of anatomic abnormality or there's an underlying metabolic disorder. So, right there, 1 1/3 have urinary tract anomalies. Again, CT scan is most commonly used because we're not going to get much with an ultrasound, but then that's in concert, usually with some consultant in the emergency department. Again, getting their pain, nausea under control. But we do not reach for alpha blockers in kiddos. Do not reach for alpha blockers in kiddos. Is alpha blockers okay to everybody else, pregnant patients, not pediatric patients. All right. Check on learning. Any questions on urologic stone disease? Lots of kidney stones in the emergency department. And even come into your TMC. I was on the forklift, I had my battalion XO, walked in, and I looked at him and I was like, oh boy, kidney stone. I just went ahead out of courtesy and called, I'm not gonna worry about it on TMC. I just called the ER and said, hey, well, he's already in my TMC, so by law, he has to ride in an ambulance from my TMC to the ER. I at least call the ER doc, say, hey, I got my China, so send him a pretty sure his kidney stuff. I can't give him anything for pain. And he said, yeah, let him lie down on a stick. This would be funny. I was like, what? He's like, no, give him 15 and Toradol. I haven't said one. I was like, cool. This would be funny. All right, questions on kidney stones, ureterolysis. that kidney stone, they should be potentially hypertense. Yeah, tachycardic, but that's not good. So we need to get an aorta ultrasound. We have AAA. We potentially say renal infarction, but I'm gonna say we need to roll with that AAA. Plus a history of hypertension. History of hypertension, not good. I think it's expanding, it's probably got to rupture. So steroids not gonna do anything, homosapiens not gonna do anything. The top three could do something, but I gotta wait on seeing that unless I'm giving it IV. A lot of work great, but she's not pregnant, right? So we're gonna reach for NSAID. Toradol, Ketorolac is pretty much the only IV NSAID that's out there, so we use it quite a bit. It's pretty effective stuff. Some bright alpha blocker. A for alpha blocker. There's some stuff. Alrighty, we're getting already close there, so we're gonna go ahead and break. Our class leader will let you know, kind of have a plan. Urologic stone disease.